Good morning, everybody. Now that we're all awake.
Only one of you guys can have your cell.
Now can you hear me? I put my volume down.
You can go ahead and turn your volume. Try to talk.
Hello? Hello, hello.
It shows that we can see you whenever you're talking.
Anuja, can you say something so I can hear you?
Can you hear me?
I hear you, yes.
You can, okay.
Just so I know, so I should.
Oh, April's actually
Thank you, April. Okay, so now I'll give you.
If anyone has any questions, please feel free to put it in the chat.
Hang on one sec.
If anyone has any questions, please feel free to put it in the chat.
You might repeat the question.
Correct.
Go ahead. So the question is to describe what precision medicine means. So what precision medicine really means is that you're trying to tailor a therapies that is specific to a patient. And an example for that would be, say, for example, we have a patient who has a mutation in factor H. And yes, we have a drug that affects the entire pathway, but there are also certain drugs in development that are looking at replacing that factor H specifically in a patient. So that is an example of precision medicine, meaning if you are targeting treatment for that specific cause of disease is what precision medicine means. So tailoring it to the specific patient rather than having one size fits all treatment for everybody. The disease actually can affect a wide range of ages. It used to be thought to be a childhood disease until some years ago. However, we know now that it's not a childhood disease. Adults and young adults, and even I have patients who up to the age of 60, 65 sometimes present with this disease. So it actually affects a wide range.
Very good question. Sorry, I decided to jump in Anuja's screen since I'm getting too much feedback over there. It's a very good question. So the USTMA consortium, and obviously TMA stands for thrombotic microangiopathy, a wide range of diseases, starting with TCP and now moving into these complement-mediated TMAs. So really, we're early in the infancy of getting medical education out there. We've done sort of Ask the Expert sessions, focusing on topics, put out 1-minute videos, and we anticipate doing the same thing very soon for the complement-mediated TMAs. So there should be more content coming, as well as there's some other videos addressing specific medical issues that might be aimed more at providers, but also patients could benefit from them as well. And those will be coming in the next 12 months, if not much sooner.
And I'll also add here, Linda, since you asked that question, and I know you're part of the AHAS Alliance, I think USTMA is doing this year, collaborating with you all, because you guys have done a phenomenal job of educating patients. I see your work all the time. I think our collaboration with you is going to take it to the next level.
Disease recurrence.
Go ahead, again.
I'll be talking about disease recurrence here in a little bit, but I'd love, that's really the elephant in the room, is how long do people have to be treated? And I had asked Anuja, so what are your thoughts on who do you think? Again, this is early in the field in answering this question, but who deserves and needs long-term treatment, and who might be able to stop complement blockade therapy?
Right, absolutely. And that's a question that I think we face day in and day out with our patients. And I kind of alluded to that a little bit in my talk, but I do think that patients who have a pathogenic mutation, if they have a mutation identified, it's a pathogenic mutation, generally we would like to keep them long-term. There are certain group of patients where we feel comfortable getting them off therapy and following them. And those patients, like I said earlier, would include those that have an acquired factor like an autoantibody, and that autoantibody has been treated successfully and they no longer harbor that autoantibody. We can potentially keep those patients off. There are certain mutations some people might consider a factor I mutation or an MCP mutation to be moderate risk. I personally don't feel comfortable taking any patients who are pathogenic off. However, if it truly is a situation where the patient can't get the drug, and it's a situation and their kidney function is completely normal. So we also decide based on what their residual kidney function. If they're completely normal kidney function, those patients, if there is a problem, may be monitored without the drug. And if with the important condition that if there is a recurrence, if there's a relapse, they have to be retreated right away without any delays. But if that's not a possibility, then we will not take the patient off that drug.
Very good. Well, I'm going to ask you this question also, since you're the nephrologist in the room, about malignant hypertension that was asked. And should patients be asking, or clinicians, the nephrologist or cardiologist, to look for these mutations? So who would you order these genetic studies in? Every patient?
Right. So that's a great question. And I think I mentioned that briefly, but I can go over in some more detail. So the question is, as a hematologist, we don't see regularly patients with malignant hypertension. And do patients, should they ask their nephrologist or cardiologist to check? Absolutely, yes. As I mentioned, as a transplant physician who sees patients at the time when they come to me for a kidney transplant evaluation. So it's a time when they've already reached end-stage kidney disease, they're on dialysis, and now they're looking for a kidney transplant. In our practice, when we see those, we go through a very comprehensive history in our patients to figure out what the cause of their underlying kidney disease is. And that is critical to understand what affected their original kidneys, because many diseases can come back or recur in the transplant kidney. And in our patients, we found that those patients, those young patients, 20 to 40, 45, 50-year-olds even, who were given a diagnosis that hypertension caused their kidney failure. We've identified those patients, several of those, we've genetically tested, and we found mutations in those patients because, as I mentioned earlier, hypertension as a cause of kidney failure in a young patient is a wrong diagnosis that should really be questioned. And I think those patients need to be tested for mutations. As I also mentioned, women who have preeclampsia and they've gone to end-stage kidney failure. Preeclampsia usually resolves after delivery, but if those patients ended up having kidney failure, I recommend testing those for mutations. And I also think, as I've showed you, a big list of thrombotic microangiopathies. There could be multiple causes, drugs, autoimmune conditions. And most of those thrombotic microangiopathies will resolve after those underlying reasons are treated. But those subset of patients who don't resolve despite treating that underlying cause should also undergo genetic testing to understand if there is an underlying genetic cause for them to have such an aggressive thrombotic microangiopathy.
There's a question that says, could you please describe your plans for the upcoming AHUS longitudinal study mentioned earlier? You see that one?
We don't, but we can answer it now.
This one, okay. Hold on. The 3 or 4 questions. So one is plans for upcoming AHUS longitudinal study. I think that's the one Shirley's doing.
Yeah.
I can take that.
You're involved with that,
A
Richard?
little bit, yeah. So there's a question in the chat asking about, can you please describe the plans for the upcoming AHUS longitudinal study? So thanks, Linda, for that question. We are in a very, very preliminary stage. We're really in the process of actually making a format or a database on what information we are going to collect. But the goal is to collect retrospective, meaning those patients who have a diagnosis of atypical hemolytic uremic syndrome, going back in their histories and collecting information about their blood work, about their genetic mutations, about what their kidney function was, did they lose a kidney, did they get a transplant, how they did after transplant. So all that information, and we're trying to do this in a multi-center way. We plan to do this and involve as many centers as we possibly can. So really the goal would be to get all that information and then understand if we can find ways how these patients did. Are there certain markers or variables that tell us why certain patients did better than others, what treatments they got? So it's in a very, very formative stage right now, and you will definitely hear more about it as we progress. We're really kind of putting our thoughts together on how to really do this study going forward.
I'm going to display the next one that says, do atypical HUS patients with coagulation-mediated TMA respond to complement blockade? Show that one.
That's an excellent question. It's been raised by myself and some of my colleagues of late in patients who may or may not have responded to complement blockade therapy. And this is an evolving area in the field. The primary difficulty is you don't get the results back for a couple of weeks, usually at least 4 to 6 weeks, depending on your lab. And then you've got time to evaluate the patient's response. And we can say they got better on complement blockade therapy. It was complement mediated. Then we find something like this and we start to question, did they get better because of the drug or despite the drug? So I wish I had a better answer. There are certainly complement mediated TMAs. There are TMAs that seem to be mediated by clotting factor issues. We talk about lupus anticoagulant syndromes leading to TMAs. And I think there's still a lot of gray area. And if you want to make it even grayer, there's some issues of complement genetic variants in patients with these lupus anticoagulant syndromes. So there's an overlap. I think we're still learning how much, and we're still learning who should maybe get anticoagulation and who should get complement blockade therapy. So an excellent question. I wish I had an answer for you.
You guys see the next one by Linda?
Yeah. The question is, will there be more emphasis on multidisciplinary TMA teams due to the complexity of disease management and extrarenal manifestations? Absolutely, Linda. You read my mind here. This is something I've been advocating for at least a few years now. It is a bit challenging, partly because not every institution has experts who know TMA. So we've talked about it at our TMA consortium. We've kind of brainstormed about it and what the best way to do this is. That's definitely the need of the hour. And I've envisioned having a hematologist, a nephrologist, maybe an OBGYN, a lab medicine person, a group that people can reach out to kind of get input. I know it's not possible for every institution, just depending on what I described, but maybe having regional teams is a solution. I do that personally in my institution, and Dr. Cataland does that. We kind of provide consultations when we are consulted, and we do that on a national level, not just for our institution. But definitely having a team is something that would be a dream come true for me. And I think we're going to continue discussions on how that can be done. But it's absolutely the need, and I would love to see that happen.
That's exactly what we do in our consortium. As our consortium was started by hematologists, but we recognize that this is a broad multidisciplinary field. In addition of nephrologists, transplant nephrologists, OB-GYN, and other pathology experts, blood bankers sort of demonstrates, I think, the need for the multidisciplinary approach. And that's really what we're trying to mirror in our consortium.
I think the next query, Margaret asked, will this study be international? I think you're talking about the AHAS longitudinal study, Margaret, here. Right now, we have not thought about that. We are really, like I said, trying to see how much we can do in the United States. But I think that's definitely a possibility for the future. If we can take this and kind of do it here, I think it's definitely worth expanding. Like I said, it's very formative right now for us to kind of even, start thinking international just yet, but it's definitely possible.
There's another question about the study, and I just wanted, if we're on a 6-month visit with our doctor, how do we get in study, or we have to wait for him?
Now, this is going to be, these studies are going to be open to all people at all sites, all USTMA sites that can easily consent the patient. You don't have to wait for a clinic visit. So anytime you're making contact with a physician, you could ask about it. I'll obviously ask you about it, April, and we'll get you enrolled. But it's an important thing. We think the more patients that are involved at more sites, the more we're going to learn. These are rare diseases. And the only way to learn more is to collaboratively work together, pull our information, both retrospective and prospective, to get a good hint at some answers and also teach us the questions that need to be asked in the studies going forward.
And you can always follow up here on the USTMA website, April. We will update it as soon as we have something going. So this will be a good spot for you to kind of find information once we have that study running.
Yeah. Really going to mirror what we've done in TTP.
Right.
We'll hear a little bit later some of the work that we've done retrospectively and are doing prospectively. And this is really a natural progression of that.
Exactly.
This is tricky.
Yeah, because it shows up here.
I'm glad you've got computer skills.
While we're waiting for more questions, you guys want to talk a little bit about the differences between the treatments that are available?
Sure. So currently, like I mentioned, the drugs that we have are the anti-C5. So they target the complement protein C5, which is kind of towards the end of the pathway. The eculizumab has been there for 10 years, and ravulizumab is the longer-acting version that has now come in. It's the exact same drug. It's just a longer-acting version. So instead, it's just given every 8 weeks. Multiple other drugs that are there, interestingly, most of them still target that same protein. And some of them, as I mentioned, are called biosimilars, which means that their mechanism of action, the protein they're targeting, how they're metabolized is very similar. I know that there's one particular drug coming out in Russia, there's another one, but those will not be available, I think, until a couple of years. So even though there are multiple different drugs, what's interesting about most of them is that they're targeting the same protein. So I think the differences there would be, and it's the right target. The differences there would really be to see if certain patients tolerate one better versus the other, and that's yet to be seen. But it would have been more interesting if we found that different drugs are targeting different different proteins in the pathway, but that's not the case. And I think the target is good. So, I think it's just a matter of waiting to see how the response is to these different medications.
I'm going to put Anuja on the spot with a tough question that I have in transplant. And so in a patient who either did not respond to complement blockade or had irreversible damage, so it's not clear if they responded, they've got no other clear etiology, hypertension, or other lupus anticoagulants, and no documented genetic variant that needs a transplant, and the issue of not wanting to trigger this disease in a family member who could carry a similar risk for the disease. And the scarcity of kidney transplants or kidney donors. How do you approach situations like that to determine, can you use a family member when there's uncertainty of diagnosis?
Right. So that's definitely a great question and a challenging question. So if I'm understanding this, the question is that if a patient who lost his native kidney, right, to a disease that was clearly thrombotic microangiopathy, at least based on biopsy, but we don't know what caused it, we don't have a genetic mutation, great. So in terms of getting that patient to a transplant, so first of all, it's what the course of the disease is in the native kidney often helps us figure out what their course will be in the transplant. So in my experience, patients who've had a TMA at a young age, those who had a very aggressive TMA, those patients are at high risk of recurrence regardless of whether we found a mutation or a cause or not. Now, the question then is, do we take a kidney from a living donor? So that really is a question that is going to require a decision together. So we typically would say that, yes, your donor may be at risk because, like I said, when we don't find a genetic mutation in a patient, that does not mean that they don't carry another genetic reason. Like I said, we only test for 13 genes in our analysis. There are 60 complement genes. So there are 40 genes that we don't test for, and that's because over the years, we don't know what their association is. And the other thing is certain patients may carry what we know as polymorphisms, which means that there are just certain benign changes in their genetic makeup that may together predispose them, but they may not show up as a pathogenic mutation. So there may be other reasons that we just don't recognize. And I think explaining that to the donor is important, that, you may be at risk if we take a kidney from you and you carry some of those factors that your recipient did. We take a kidney from you, you're at risk. And I think our recommendation would be, I'm concerned to take you as a donor, but if the donor and recipient understand that risk very clearly, I think we would probably go ahead.
Good. That's a good question. I always get that question of who's going to take on the risk. Transplant programs obviously don't want things to happen to donors.
Yes, and so if the donor and recipient are we think that they're understanding and they're educated and we can explain to them, and the donor says, you know what, that's fine. I mean, especially if it's a mom or a dad and it's a younger child and they're willing to take a risk for that, we might go ahead with that.
Well, thank you.
Answer the question by April.
I need a kidney. How would I go about getting my family tested for AHAS to see if they can donate, and would insurance pay for it? Great question, April. So first of all, my question to you is, yes. So yes, we do. If you're looking for a transplant and you have an atypical hemolytic uremic syndrome as a diagnosis, and you've had genetic testing done, if you have a family member who wants to donate, we are going to recommend testing. Now, in terms of would insurance pay for it, here's what my experience is. That if your donor is accepted as a donor, so what we do is we work you up for a kidney transplant, and then you have a donor who comes forward, and we work up the donor for a kidney transplant. Now, as part of the donor workup, we want to know whether that patient can be acceptable. In those cases, I know that the recipient's insurance will cover all the donor testing that we do. But if you're talking about just looking at all family members, just to know what their risk of atypical hemolytic uremic syndrome is, that really depends on individual insurance companies. I've had 50% chances where the companies might say yes, and other times no. So it's not a uniform answer. It really depends on your insurance. But if it's a specific donor, then that donor's workup will be covered.
Does it matter that she has factor H?
Yeah, exactly. So if you have factor H mutation and you're looking for a kidney and your donor is coming forward, yes, extremely important that your donor be tested. And I think that should be covered by your insurance as a transplant workup.
I think the real difficulty becomes when a patient clinically we think has a complement-mediated TMA or atypical HUS, and they have no identifiable genetic variant, then you don't know what to look for in a family member or donor. That's where it gets tricky. Excellent questions, though.
Ask if there's any other questions.
Yeah, feel free to ask. We have a few minutes left here, about 2 or 3 minutes. Any other questions anybody has?
I think we have a private chat option. I'm not sure if that's functional for you guys. And if you want to send something that you don't want to put in the comment chat, that's fine.
But we certainly appreciate your involvement in this field of complement-mediated TMAs as our consortium expands into this more and more. As many of our members do both. Some do one, some do the other, but it's a great collaborative resource.
Absolutely.
Very good. Well, thank you everyone for your attention and for participating.
All right, thank you. It was nice, great questions. And I think you can probably send questions afterwards too. Is that right? Yeah, if there's somebody who thinks of anything else later on, I think you can contact the consortium.